Hello and welcome to eXPLAINED. In this talk, we're going to discuss about lid margin keratinization. This is a favorite topic of mine. I'm going to begin by explaining to you what the normal lid margin looks like, what is keratinization, how the lid margin gets keratinized, what are the clinical implications of a keratinized lid margin, specifically the posterior lid margin, how we can fix that, what are the principles that we need to remember when we are addressing lid margin keratinization, and in the process I am also going to briefly touch upon why I find this term lid margin keratinization, although it is very commonly used in clinical practice, why I find this term a little bit problematic, and I think that it can be replaced by something that is more descriptive and better describes the condition, is easier to recognize if you use an alternative terminology, and why the semantics is important in recognizing and treating this condition. Alright, so this is how the normal lid margin looks like. On your left is a schematic where you can see that the lid has been split into the anterior lamella and the posterior lamella. You can see here that this is the anterior lamella consisting of the muscle and the eyelashes, and this is the posterior lamella consisting of the meibomian glands, and within the consisting of the tarsal plate, and within the tarsal plate the meibomian glands. Where the anterior lamella meets the posterior lamella, this is called the gray line, simply because it looks gray. So you can see it's very easy to make out here in the upper lid and also here in the lower lid. And the gray line is where the muscle of rheoline attaches, and it's an anatomical landmark and a surgical landmark. All right, it does not have any other functional importance. If you look at the lid margin in the cross section, this is a histology describing what it looks like. Very important to recognize that because of the presence of the tarsal plate in the posterior lamella, and the tarsal plate, as you know, is hard and it's rectangular in shape, and because of that it gives the posterior lid margin a kind of a very sharp edge. It's not rounded like the anterior lid margin. The anterior lid margin is rounded. You can see here that the muscle is there, and you can also see the hair follicle and shafts. And in the posterior lamella, of course, you have the tarsal plate and the meibomian gland orifices. The epithelium over the lid margin is also very interesting. If you look anteriorly where the hair follicle is, you will find that there is keratinization because of the presence of skin here. Now, what essentially is keratinization? Keratinization means that, and this is seen very commonly on the skin, all right, and it is also seen in specific areas of other mucous membranes. For example, if you look at the mouth, most of the epithelium in the mouth, the oral mucosa, is non-keratinized except the hard palate, for example, which is keratinized, and it has to do with how well lubricated the surface is, etc., etc. In the ocular surface, all epithelium is non-keratinized. So all the conjunctival epithelium, all the corneal epithelium is non-keratinized, which means that it does not have the stratum corneum. What is the stratum corneum? So as the epithelial cells, you know, the basal cells are the ones which are more proliferative, and as the cells grow older, they kind of move up, and the cells on the top are the oldest and the most mature cells, and eventually these cells die and they collect on the surface. Now, in the skin, what happens is the dead cells collect and these cells degenerate, and then only the proteinaceous material within these degenerated cells remains, and it forms kind of a sticky layer, which is the stratum corneum, all right, or a layer of keratin. So normally this is seen in all over the skin, but you are not supposed to see it on the conjunctiva or the cornea, primarily because the eye, as you know, the ocular surface is continuously washed by a layer of tear film, and the tear film keeps washing away the debris and the dead cells, so they don't get the opportunity to collect on the ocular surface and therefore form this keratinized epithelium. When can the lid margin get keratinized, therefore? So if the skin, which is keratinized, which is located here, it has the opportunity to move posteriorly and replace the conjunctiva, then the lid margin can get keratinized, all right. If you look closely, then you will see the difference between the keratinized and the non-keratinized epithelium. So, I want you to pay attention here. This is a higher magnification photograph of the mucocutaneous junction at the posterior lid margin. So, you can see here this is the anterior part, and in the anterior part you can see that there is epidermis, and you can see these digitations. Okay, these are this is how the dermis epidermis junction looks like, and on top you can see these layers of keratin, right, and this is basically a higher magnification of that. So, this is epidermis, whereas if you move more posteriorly along this, you will see that here the epithelium, which is the conjunctival epithelium, there is no keratin here. You do not see this keratin over here, it is not there. So, in the normal lid margin, posterior lid margin, there is no keratinization. In between where the epidermis ends and the conjunctiva begins, there is what is known as a transitional zone. Okay, here again the epithelium is not keratinized, but it is not completely conjunctival in phenotype, and the mucocutaneous junction is located just posterior to the meibomian gland orifices. That is where the transition from the epidermis to the conjunctiva begins. All right. So, remember that in a normal lid margin, the epithelium is normal posterior lid margin. The posterior lid margin is basically this. All right. This is, and I will tell you why this is called the lid wiper later on. So, here the epithelium is conjunctival in phenotype and it is not keratinized. You do not find this keratin over here normally. Okay, and there is a junction in between similar to the junction in between the cornea and the conjunctiva, like you have the limbus on the surface of the eyeball. At the lid margin you have the mucocutaneous junction, which is the transitional zone between the epidermis on one side and the conjunctiva on the other side. So, let us identify these landmarks here in this photograph. Like I described to you before, this is the intermarginal strip or the lid margin in totality. The gray line which you see here divides the lid into two halves. So, we have both the upper lid and the lower lid. This is the anterior half or the anterior lamella. This is the posterior lamella. So, the meibomian gland orifices are in the posterior lamella, the eyelashes are in the anterior lamella. Similarly, in the lower lid, the eyelashes are in the anterior lamella, which is over here, and the meibomian gland orifices are in the posterior lamella, which is over here. All right, and we know, and we have already mentioned this, that this is the gray line. All right. So, where is the mucocutaneous junction? That is the important question here. Okay, and if you look closely, now this is an higher magnification photograph of the everted upper lid. So, you can see the lashes here. So, this part of the lid is obviously anterior, and this part of the lid is the posterior half or the posterior lamellae. If you look here, then you will notice that in addition to the gray line, you will also see, if you look carefully, that there is this shiny white line that you can make out, particularly towards your left and also slightly over here towards your right. It is in continuity. This is known as the mucocutaneous junction. So, the mucocutaneous junction is actually not something that you can only see on histology. You can actually see it clinically, but you have to know how to look for it. So, in normal lids, it is seen as this shiny white line, particularly in eyes that are wet. And I will also show you how you can easily recognize the mucocutaneous junction by using fluorescent staining in the subsequent slides. Just to reiterate, this is the gray line and this is the mucocutaneous junction. Okay? The mucocutaneous junction is this shiny white line that you see here. And lastly, I want to emphasize this, that the gray line is anterior to the meibomian gland orifices, all right, whereas the mucocutaneous junction is posterior to the meibomian gland orifices. It is just posterior. So, if you look without all the markings, the annotations here, these are the individual meibomian gland orifices. And if you notice carefully that the shiny white line, which is the mucocutaneous junction, is just posterior, just about posterior to the meibomian gland orifices. This is very, very important, okay, this landmark, that it is posterior and the gray line is anterior, because this has implications when we do surgery. When you stain with fluorescein, what happens is that the mucocutaneous junction is actually there is a slight depression, okay, anatomically. So here there is a very, very subtle guttering at the mucocutaneous junction, and because of this, when you put fluorescein and it mixes in the tear film in the cul-de-sac, a little bit of it pools at the mucocutaneous junction, and therefore it becomes very easy to pick up the mucocutaneous junction when you have fluorescein staining on the ocular surface. So you can see this line really lights up now that with fluorescein staining. So this is the mucocutaneous junction. Again, just to reiterate, it is very, very distinct from the gray line. The gray line is somewhere over here. You can see the meibomian gland orifices here, and you can see the eyelashes here. So this is anterior lamella, this is posterior lamella, and the gray line is somewhere in between them. But the mucocutaneous junction and this is just posterior to the meibomian gland orifices. All right. So now you know where it is located, mucocutaneous junction, and how to discern it clinically on normal examination, and also if you're having difficulty in figuring out where it is by using fluorescein staining. The importance of the mucocutaneous junction, and why in the earlier slide we talked about the lid wiper, is the fact that the mucocutaneous junction, and you can see again over here that it is located right at the posterior lid margin over here, is the part of the lid, both in the upper lid and the lower lid, which comes in contact with the ocular surface and also the tear film. So if you were to trace the tear lake or the tear meniscus over here, you would find that one of the basal apices of this triangle comes in contact with the mucocutaneous junction, which is at the posterior lid margin. So it's easier to make out here in the fluorescein stain that it's exactly over here where the mucocutaneous junction is that the tear film and the ocular surface come in contact with the lid, and that is why the mucocutaneous junction is also known as the wet line. Okay, that is another terminology which is used to refer to the mucocutaneous junction. It's known as the wet line. Important to note here that it comes in contact with the limbus. You know that in the normal anatomical position, if you look at the eye and the position of the lids, the upper lid covers about the superior 2 millimeters of the cornea, and in lower lid just about touches the limbus. Now this is important because both the upper lid and the lower lid at the mucocutaneous junction, that is where the contact is between the lid and the limbus, and you know that the limbus is important because the limbus contains the stem cells. You can see very clearly the limbal palisades over here, you can see them very clearly over here, and therefore the health of the corneal surface is closely linked to the normal anatomy and function of the posterior lid margin. So if there is something wrong with the posterior lid margin, then it directly impacts the stem cells at the limbus, and you also know that the stem cells are most populous in the superior and inferior limbus, and that is exactly where it comes in contact with the lid, and therefore the importance and relevance of the posterior lid margin in the mucocutaneous junction. If you look closely at these photographs, you will notice that there are very subtle signs of keratopathy in both eyes, and this is particularly apparent in the fluorescein stain photographs over here. So you can see that there is an area of staining that is localized nasally in the right eye, both superiorly and inferiorly. There is this area of staining, scarring and vascularization. You see some vessels coming in over here in the superior limbus in the left eye, and also a similar area of staining here. There is also staining in the center, all right, in both eyes, but the superior and limbal staining is very subtle, and you need to pay attention to this. So whenever you see a case like this, you have to suspect that something is going on with the lid margin, because the area that is affected is superior and inferior. Similarly over here you can see that there is affection of primarily the nasal half. Now why is this happening? Okay, if you invert the lids in this eye and look at the everted lid, you will see that the mucocutaneous junction is not normal, and the abnormality in the mucocutaneous junction explains the fluorescent staining. So if I were to ask you to trace the mucocutaneous junction in both the upper lid and the lower lid, in the right eye for example, you would see that this has migrated posteriorly over here. So this line should have proceeded along the just posterior to the meibomian gland orifices, but there is an area of posterior migration of the mucocutaneous junction over here nasally. Alright. Similarly, in the lower lid you see that it is more or less normal up till here when it starts to migrate again posteriorly. So it should have been here, but there is about 2 to 3 millimeters of posterior migration. Similarly, in the upper lid you can see that there is gross posterior migration. So this line should be just posterior to the meibomian gland orifices here, but almost all throughout it is posteriorly migrated. Similarly, in the lower lid you can see that there is a certain amount of posterior migration over here. This line should have been along just posterior to the meibomian gland orifices over here, but there is, you can see, about 2 to 3 millimeters of posterior migration of the lid margin over here. And now when you understand this and you go back to the previous photograph, it makes perfect sense, right? So now it explains why there is staining over here only nasally, and why there is a concentration of staining superiorly and inferiorly. There is also staining centrally, but this staining is because there is dryness on the surface, right? So this patient actually is a patient of Stevens-Johnson syndrome, and the patient is developing keratopathy in both eyes because of the posterior migration of the mucocutaneous junction or lid wiper keratopathy. And this staining pattern that you see here, which corresponds to the pathology on the lid, is what I like to call differential staining. So if you see differential staining, then you know that the keratopathy that you are seeing on the corneal surface is actually due to the lid pathology. All right. So now you know how to identify the mucocutaneous junction, and also how to identify if there is an abnormality in the mucocutaneous junction, if it has moved anteriorly or posteriorly. Mostly it moves posteriorly. All right. Sometimes you can have an anterior migration of the mucocutaneous junction also, extremely rare, I have seen some cases, but mostly it's posterior migration. This posterior migration of the mucocutaneous junction is what is known as lid margin keratinization. All right. However, like I was mentioning before, that I would prefer using the term posterior migration of the mucocutaneous junction rather than using the term lid margin keratinization. Okay, and I'll tell you why. That is because keratinization, like I showed you in the histological sections before, is something that you can only see under the microscope. All right. You cannot diagnose keratinization just by looking at the change in the color. It is something that you can only diagnose on the microscope. Sometimes the keratinization is very obvious and it is easy to diagnose clinically, but in many cases it is not so obvious, it is more subtle, and therefore if you learn to look at the mucocutaneous junction and see if it is posteriorly migrated or not, that tells you more easily whether there is lid margin keratinization than trying to look for keratin or keratinization, because there is no standard way to define what keratinization looks like. Okay. This is another example, and here I will tell you there is obvious keratinization, which is easy to diagnose. In the earlier case, it was more subtle. You will only need to know how to look at the mucocutaneous junction. If you need to know that, you will be able to diagnose it. Otherwise, you will miss it. Okay, because you are trying to look for keratinization that is staring you in the eye, and this is a case where keratinization is staring you in the eye, and this is the conventional way that keratinization of the lid margin is. Obviously, this patient has bilateral, very severe ocular surface disease. If you evert the lids, then you see this gross keratin plaque deposition, and this is typically what people have learned to recognize and interpret as lid margin keratinization. Yes, obviously, this is lid margin keratinization, but this is very, very severe, advanced, and it is associated with what I call keratin plaque deposition. All right. So, keratinization may or may not be associated with the keratin plaque deposition. Here you can obviously see that there are huge amounts of keratin that is deposited, and therefore it makes, and you can see how irregular the lid margin is. So, here this is posterior migration of the mucocutaneous junction, which means that there is lid margin keratinization, but there is also, because of severe inflammation and chronicity, there is also keratin plaque deposition, which makes the diagnosis of lid margin keratinization very obvious. Now, you should read this paper by Sorzono in Ophthalmology 2007, where they teach you how to identify the mucocutaneous junction and how to recognize how distorted the mucocutaneous junction is, and you can actually grade it from grade 0 to grade 3 in the order of severity based on the amount of distortion. So, you can see in grade 2 that the mucocutaneous junction is grossly distorted, and it is going back and forth over here, whereas in grade 4 again you can see that it is really distorted over here, and you can easily pick up even subtle distortions like grade 1 over here by using fluorescent staining. Okay. Now, if you are only looking for keratin plaques to diagnose lid margin keratinization, then you will be able to diagnose this, but you will miss all of these, particularly the grade 1. And therefore, and this is why I am re-emphasizing that learn to recognize the mucocutaneous junction and learn to recognize posterior migration of the mucocutaneous junction, and use that term preferentially to lid margin keratinization, because then you will be able to diagnose more subtle forms of lid margin keratinization, which you will otherwise miss if you are only looking for gross keratin plaque deposition, which is how lid margin keratinization is conventionally defined. This happens because of ulceration of the lid margin, most commonly in Stevens-Johnson syndrome or SJS or toxic epidermal necrolysis, but there are other conditions also which can cause this. And when these ulcers heal, it heals basically from the skin side, and therefore the skin overgrows the lid margin and causes a posterior migration. You see the skin coming over. Now, but when the skin covers the posterior lid margin, and because the posterior lid margin is the part of the lid which comes in contact with the cornea, this constant rubbing or lid wiper keratopathy of a keratinized surface rubbing against the very delicate epithelium of the cornea and the limbus causes a chronic keratopathy, which basically is what we call lid wiper keratopathy. So, this is an example of a lid margin where you can see that the meibomian glands are atrophied, and this is also something that I wanted to point out, that if you are diagnosing somebody with lid margin keratinization or posterior migration of the mucocutaneous junction, and like we mentioned earlier in the slides, that the posterior migration may not be uniform from canthus to canthus. There may be focal areas which are spared, but in the areas that you are diagnosing with posterior migration of mucocutaneous junction, it is absolutely mandatory that if there is posterior migration, and these two things go together, that if there is posterior migration, then the meibomian glands are also atrophied in those areas, because the epithelium, as it grows, it also grows into these meibomian glands and they block the orifices and the glands atrophy over time. Here the atrophy is very gross, and you can see that the mucocutaneous junction is now over here, and it should have been somewhere over here, but it is grossly posterior migrated. So, you will see that this is a very, very large area, and obviously you can understand that this posterior lid margin, which is over here, is now covered by a keratinized epithelium which is constantly rubbing on the cornea, and that will obviously over a period of time cause keratopathy, which may initially be just SPKs and vascularization and scarring, but eventually will result in limbal stem cell deficiency and epithelial defects and so on and so forth. Now, I also want to reiterate again that please try to stain and look for the mucocutaneous junction, trace it, and this will help you in accurately identifying the extent, the irregularity, the severity of the posterior migration of the mucocutaneous junction, rather than trying to look for obvious keratin plug deposition, which occurs in a large number of cases, but not in all cases. Okay? In the photograph on your left, you can see that there is a distortion of the mucocutaneous junction, and if you trace the mucocutaneous junction, you can see that it is not uniformly posterior migrated. There is a part in the center where the mucocutaneous junction is actually normal. You can still see the meibomian glands in progressive atrophy, but there are these tongues of keratinization which have progressed posteriorly, both medially and laterally, but the central mucocutaneous junction is somehow spared. But this is also gross distortion. This would come under grade 3. All right. This is very different from the photograph on your right, where there is almost uniform posterior migration of the mucocutaneous junction. It should have been somewhere over here, but this is the entire and also associated with what I referred to earlier as a keratin plaque. All right. And this kind of in your face, very obvious keratinization is easy to pick, but the more subtle abnormality or irregularity of the mucocutaneous junction is more difficult to pick, and therefore learning how to recognize the mucocutaneous junction, looking for the staining and identifying the line will help you in recognizing these irregularities. And I am mentioning this again and again just to emphasize this point. Now, we mentioned about this case earlier. Here you trace and you figure out the abnormality, and you can see here that medially there is posterior migration in the right eye in both the upper and the lower lid, and in the upper lid there is a more or less uniform. So, again two different patterns of keratinization that I am trying to demonstrate here. In this individual, because of skin pigmentation, it is very easy to make out, the demarcation is very obvious, but in those people who are lightly pigmented, this may not be so obvious. So, you have to recognize, and usually the presence of the keratinization corresponds to the keratopathy, and you can recognize this, and that the keratopathy is attributable to the keratinization because of the presence of the differential staining. So, we have covered this part. Now the question is, what can you do to fix this? Okay. So, what can we do to fix this posterior migration of the mucocutaneous junction, because this is causing keratopathy, and if this keeps on happening, then over a period of time the cornea can get really damaged beyond a point of no return. So, this can be fixed by doing a surgical procedure which is known as mucous membrane grafting, or MMG. Where does this mucous membrane come from? This mucous membrane comes from, we usually take it from the lips, so it is labial. You can also take it from other parts of the oral mucosa like the cheek. The lips are particularly easy to harvest from because they are easily accessible, and therefore most people prefer using the lip mucosa for mucous membrane grafting. What we have done here is that we have replaced the keratinized mucosa or the keratinized conjunctiva by a smooth non-keratinized epithelium harvested or obtained from the labial mucosa, the oral lip mucosa. What I want you to pay attention to here is the incision which we have made. This incision is actually at the gray line. Okay? The incision is not at the mucocutaneous junction. So, what we have done in effect by putting the mucous membrane graft is that we have anteriorly advanced the mucocutaneous junction. The mucocutaneous junction should have was over here, as we saw in the earlier photograph. Okay, it had posteriorly migrated here, should have been somewhere over here, just posterior to my mammalian gland orifices. And when we did the mucous membrane grafting, we advanced it by a millimeter or so, because we put the anterior incision at the gray line. Now, why do we put the anterior incision in the gray line? And I think this is a very, very important conceptual thing that everybody needs to understand, for two reasons. One is technical. Like I told you before, the posterior lid margin is right angled. Okay, it has a sharp angle, sharp. So, if you want the mucosa to wrap around this sharp bend, there has to be enough mucosa on both sides. Okay. So, if you put the incision on exactly at the posterior lid margin, your mucosa will basically just hang by a little bit of a thread, and it will not have enough to wrap around it, and it can easily slide a little bit posteriorly, and you may lose the effect of the mucosa. And this I have seen very commonly in those surgeons who prefer to use an incision posterior to the mammalian gland orifices or at the actual site of the mucocutaneous junction, that after the tissue remodels, after mucous membrane grafting, the skin migrates a little bit posteriorly because of the give and take of the wound remodeling, and the actual uptake of the mucosa is somewhere posterior, and therefore the entire surgery loses its point, because now you have excellent lip mucosa on the tarsal plate, but none of it wrapping around the posterior lid margin, which was supposed to be how it was going to prevent lid viper keratopathy. So, please remember that the point of doing this surgery is to anteriorly advance the mucocutaneous junction. Like I said, two reasons. One is the technical issue of there being enough mucous membrane graft, about a millimeter to a couple of millimeters on either side. Usually it's about 1.5 millimeters, so that there is enough of a wraparound effect. And the second important part is, like I mentioned before, that whenever you do this surgery, there is always a little bit of a give and take at the junction. Okay, because it is very, very common for the mucosa in the eventual way that it takes up to be a little bit eventually behind where you put it. Okay. So, over a period of time, the lip mucosa and the skin will migrate a little bit posteriorly, and the eventual boundary that will be set will be a little bit behind where you originally placed the mucosa. Now, if you have anteriorly migrated the mucocutaneous junction, then even when that give and take happens, the final position where the mucosa settles down is still anterior to the posterior lid margin, right. So, you still have mucosa wrapping around it, and this is basically the effect that you want. So, important that when you are putting your incision for anterior incision for your mucous membrane grafting, this incision has to be at the gray line and not at the mucocutaneous junction. And the idea of this surgery is to advance the mucocutaneous junction so that it can wrap the lip mucosa, which is wet and which is non-keratinized, can wrap around the posterior lid margin, all right, and give the posterior lid margin, not the tarsal plate. Okay, the posterior lid margin can restore the smoothness and the non-keratinized covering of the posterior lid margin. That is the objective of doing this surgery. The objective is not to replace the tarsal keratinization, but to restore a smooth non-keratinized epithelial covering over the posterior lid margin. All right. So, the operative term here is posterior lid margin, and this is very, very important to understand, that if you have only the mucosa left over on the tarsal plate, that doesn't serve any purpose. It works, the surgery works only if the mucosa remains forever wrapping around the posterior lid margin. All right. So, if you can do this surgery well, you can actually mimic very closely how the normal appearance of the posterior lid margin is by doing your mucous membrane grafts. And there are a lot of technical tips and pearls that you need to learn to do the surgery well, so that your outcomes are both functional and cosmetic, and we will reserve those tips and pearls for a subsequent talk on lid margin mucous membrane grafting per se. But I have just kept this photograph to show you how beautiful both anatomically and functionally the outcomes of this surgery can be if you learn how to do it correctly. And this fixes a very, very important problem, and therefore you can completely prevent keratopathy due to lid margin keratinization from developing or progressing in patients who have this problem. And therefore, particularly in those subset of cases where there is keratinization or posterior migration of the mucocutaneous junction and the patient's eyes are not completely dry, mucous membrane grafting has a dramatic effect. The patients will tell you how much of a difference you've made in their life. They can open their eyes, they can see better, their vision improves, their comfort improves, and it really is life changing for them. So it's a very, very important surgery to learn if you have patients with ocular surface disease, particularly patients with Stevens-Johnson syndrome who usually have lid margin problems and posterior migration. And just to finish with an illustrative case, you can see here again very, very clearly what I talked to you about: differential staining. You can see that there is staining superiorly, inferiorly. There is also staining in the middle, and that is because of the dryness of the exposure, but there is obviously staining superiorly, inferiorly, and you can clearly see that there is a lot of distortion in the mucocutaneous junction, both superiorly and inferiorly. And if this can be adequately addressed by doing a good mucous membrane graft, you will see how well the improvement is on the ocular surface. Now, very, very important here to note that now that we have addressed by doing the MMG the keratinization or the lid wiper keratopathy, the differential staining disappears. So now you do not see staining superiorly and inferiorly anymore, but you still see staining in the center, and this is because of the dry eye component. So initially the patient had staining because of two issues. Okay, now I just put this slide just to explain this to you, that you had differential staining because of the lid wiper keratopathy, and you had central staining because of the dry eye. And when you have addressed the lid wiper keratopathy by doing a very nicely done mucous membrane graft, the differential staining disappears, has gone, and you are only left with the dry eye component. And because the differential staining is gone, which basically means that the stress that was there on the superior inferior limbus because of the keratinization has now been relieved, and therefore there is a good chance that by giving the patient lubricants, by giving the patient surface protection, maybe scleral lenses, you will be able to maintain this surface for the rest of the life of the patient. But if this is not done, then this keratopathy will keep progressing. You will lose the stem cells that are there at the superior inferior limbus, and eventually over a period of time the surface epithelium will start to break down, and then you will get into really big trouble. So it has a great prophylactic or preventive role and in preserving corneal health. All right, so just to summarize, I have explained to you what is the normal anatomy of the lid margin, and if you have understood me correctly, you will realize that this rounded margin is the anterior margin which has the lashes. This sharp margin is the posterior margin which has the meibomian glands in the tarsal plate. The point at which the anterior and the posterior lamella meet is the gray line. The mucocutaneous junction lies just posterior to the meibomian gland orifices, and it is the mucocutaneous junction which actually comes in contact with the cornea, particularly at the limbus where the stem cells are there, and therefore it is absolutely essential for the posterior lid margin to be covered by normal non-keratinized epithelium. We have talked about how the epithelium over here over the skin has keratinization, but over here it does not. But in certain pathological conditions like SJS, it might get keratinized, and then it can cause keratopathy because it will be rubbing on the cornea and can cause permanent damage to the stem cells as well. All right. I also talked about how you can identify the mucocutaneous junction clinically by looking at the shiny white line or by using fluorescein staining to look at it, and you can actually identify the amount of irregularity in the mucocutaneous junction when you look at the lid in profile, and you can say, okay, the mucocutaneous junction should have been here, but it is migrated here, so there is posterior migration. And I wanted to reiterate this point right at the end that I prefer the term mucocutaneous junction and the posterior migration of the mucocutaneous junction as opposed to the term lid margin keratinization. And the reason that I say this, and I explained this before, is that you can actually see the mucocutaneous junction, you can identify it clinically, you can grade it, you can know exactly how much it has migrated, and that helps you take a decision or understanding how much of an effect it is having on the keratopathy. Keratinization is something that you see under the microscope in histology slide. The clinical correlate when it is very severe, it's obvious, you can see keratin plaque and you know it's keratinization, but there can be more subtle forms of keratinization where unless you know how to identify the mucocutaneous junction, you will miss them. And therefore, I think and hopefully we can develop consensus and move forward in the future and try to use the term mucocutaneous junction and posterior migration of mucocutaneous junction as opposed to talking about lid margin keratinization alone. And I hope that this talk has been helpful. It has explained some very basic concepts to you, and also the principles based on which mucous membrane grafting for lid margin keratinization is done. I would love to hear your feedback on how we can improve on these talks and what are the other topics that you would have me talk about. So please put in your comments and I'll be happy to read them, and I will be very glad if you can share your feedback. Thank you so much, and until next time, bye bye.